I'm going to talk to you from the perspective of having been in palliative medicine for decades and having looked after thousands and thousands of people who are dying and had lots of conversations with them about their dying. Now, the question really before you is it physician-assisted suicide or euthanasia or none of those, and what happens? And Cicely Saunders pointed out that how people die lives on in the memory of those left behind. And that becomes important because palliative medicine is a new specialty and discipline. It's changed very rapidly in recent years. People who watched a bad death 20 years ago, that will be emblazoned on their memory, but that doesn't mean that that's how people are dying, need to die today. Things have changed a lot. And I would just point out to you that New Zealand comes third in the world ranking of palliative care, the quality of palliative care services. So you're doing incredibly well, and you do have specialist palliative care that is superior to the services in countries that have changed their laws. Now, there is this myth, really, that you either have suicide or you suffer. And I would suggest that it isn't a choice between do you take your own life or are you forced to live on, because nobody's forcing you to live on at all. You can stop or not start treatment at any time that you want, and those looking after you have a duty of care and must do all they can to ensure that your quality of life is maintained and enhanced as much as possible, that your dignity is maintained, and that your wishes in terms of what you want to do in however much time is left to you are actually fulfilled. You will not be abandoned. The doctor has a duty of care, and that is actually what happens in practice. Now, let me just give you a very clear example of it, rather than the theory. Take someone with motor neurone disease who has become dependent on a ventilator and who says, I've had enough, I don't want to carry on, I just want to die. And if you, as the doctor, and I've had these conversations with people, can see that the person actually is now refusing the treatment that you're offering. You have to remember, each time you put them back on the ventilator, you are instigating a treatment, and they are completely within their rights and able to refuse that treatment. If you treat them against their will, that is assault. It's the same as if you give blood to a Jehovah's Witness. A Jehovah's Witness will say they don't want a blood transfusion, they refuse it. You cannot transfuse them against their will. Okay, so what do you do? Well, if you're taking them off the ventilator, you don't just abandon them and leave them. There's very clear protocols about managing their care so that they die peacefully, gently, with dignity, and this protocol has been audited and it's doing fine. And the time from stopping the ventilation to death is actually really very short. But people die quite peacefully with their families around them. Now, what do you do in euthanasia or physician-assisted suicide? And if I can just show you on this one, they would have died if they hadn't been on the ventilator. The ventilator has been keeping them alive, and when they refuse it, they die of their motor neurone disease that they would have died of previously. Completely different to euthanasia or physician-assisted suicide, where you give a lethal dose of drugs to bring about death as fast as you can, irrespective of how much longer the person might have lived for. And you do not know how long that is. So what do you actually do? Well, physician-assisted suicide you've heard about. It's a massive overdose. You can take 50 tablets of barbiturate crushed up, or it's a tumbler full of barbiturates. It tastes pretty filthy and you swallow it down yourself. With euthanasia, the doctor injects you with lethal drugs. So that's really the difference between the two. In the assisted suicide, you do it yourself, you drink it down. With euthanasia, you put your arm out. So what about the medical criteria that you've heard about? Well, Robert's already touched on prognosis. Actually, in the Select Committee, we heard that about 5% of diagnoses are wrong at post-mortem. We're not actually always terribly accurate with diagnosis. That's the reality. There are diagnostic errors. But prognosis, you certainly can't accurately predict how long people will live. My biggest error was in 1991. I saw a man referred to me actually because he was desperate for euthanasia at the time. And 4 of us, I, 2 other consultants and his GP, all thought that he would be dead in 3 months. He is still alive today. In fact, only an hour ago, I had a message from him to say that he couldn't come to a dinner that I'd invited him to come to as my guest. And he says, just don't go there, because in the interim, his wife has died, and he's been left to bring up the children who would have otherwise been orphaned in care. Now, you've heard about mental capacity. Well, it's not very easy to assess. A third of people with neurological disease who look at first sight to be completely compos mentis, if you test them properly, they actually do have quite severely impaired capacity. And depression, as you've heard, is missed. And it is difficult to diagnose, but it is a reversible condition and treatable. What about the social criteria, though? These are the ones that worry me most as a doctor, because I cannot judge them. I do not know what goes on behind closed doors. We know about elder abuse. I know that you've got a problem in this country about elder abuse. We've got a problem about that at home as well in the UK. But what about the internal pressures? Fear of being a burden, don't want to be thought of badly. External pressures, the cost of care. I'm afraid over the years I've been taken in by families. Not all families are loving families. Most parents love their children, but not all children love their parents. And I'm afraid that's just a reality. And when there's money at stake, sometimes people are really not as concerned. But I've been completely taken in by families, and it was only after somebody had died that we realised that we'd been hoodwinked, basically, that they weren't a loving family. And what about societal things? Well, the problem is that once you get something normalised, it can become an expectation. So with the diagnosis of a serious illness comes the expectation in conversation, and so when are you going to go for euthanasia? And that in itself normalises and puts a pressure on. And for you, as the patient, you have to think, should I be going for it now? Or should I wait a bit? What should I do? So in fact, there's an additional burden. But the other thing I want to cover, as a doctor, I think I can say it, is that we do have power and influence, however much we try not to. However much we try to be in an equal relationship, when you have knowledge about an illness and you know about what's happening to somebody, the person is dependent on you for information. The way that you give the information, the way you respond to a patient will steer them in one direction or another, just like the handlebars on a tandem, really. How you steer them. And the person who says, I just want to die, you can respond to, and I hope every doctor would respond by reflecting, so you really want to die, and listen to whatever it is that's causing them to feel like that. But then when you start to process a request, you give a subliminal message that actually, I agree, you'd be better off dead. In fact, I'm doing this because it's in your best interests. Because I, as a doctor, know things that actually, they may be so scary I don't even dare talk about. But the message is that I think that you'd be better off dead. If you can't do that, and you go back and you explore what's making today so terrible and what can we do to improve it, then usually, in fact, I'd say almost always, in my experience, we found that these are actually social concerns, things that have been worrying people. Oh, I didn't want to bother you about that, and so on. But you can really make a major difference. But you also give a subliminal message, which is that you are worth me working hard to improve things. And I am committed to doing that. So it's quite a different message that you give. Why do I say it's not for doctors? Well, we know in Oregon, where it's been within their law now, 2/3 won't participate. So it isn't fair to say people are frightened of being prosecuted, because they wouldn't be prosecuted in Oregon, but they just don't want to get involved in this. But of course it means there's doctor shopping. So the patient then goes to see somebody who knows nothing about them other than what's written down in the case notes, and is making a face value judgment, and it is the doctor who is the gatekeeper. Don't anyone think this is the patient's choice, really. It's the doctor who's deciding either you fulfill the criteria or you don't. So you're putting in the doctor in a position of judgment. From Oregon, we know that although most doctors won't do this at all, last year one wrote 25 prescriptions. In 1 year before that, they'd written 27 prescriptions. 25 prescriptions seems to me to be a lot. It's about 1 a fortnight. In the UK, from a survey of GPs, we know that 6 out of 7 will not do the assessments and the supply and prescribing of drugs. They don't want to do it. And I would suggest this is not a job for doctors. It is too dangerous. What are the drugs used? Well, this is not a little bit more of morphine to make you comfortable as you are dying. That's not what you use. In fact, it's really difficult to kill people with morphine. The Dutch tried to use it initially and found that it didn't work, so they abandoned it because people woke up again. And I've had patients who've had massive overdoses because somebody's made a drug error or whatever. They just have a jolly good sleep and wake up and say they feel better. That's just the reality of it. So what do you do? For assisted suicide, it is a massive overdose of barbiturates, 9 or 10 grams. You would never prescribe that therapeutically for somebody. It's a fixed dose. And for euthanasia, you inject a short-acting anaesthetic agent, and if the person doesn't die with that because they've stopped breathing, then you paralyse them completely with curare so they don't breathe. They die of asphyxia. That's the reality. That's what you do. And there isn't really evidence, strong evidence of covert euthanasia. There is a misunderstanding out there amongst doctors, nurses, and the people across the population. When someone's been given a last dose of medication, a last dose of morphine, and then they die, people can feel, gosh, if I hadn't given them that injection half an hour ago, perhaps they wouldn't have died. There will always be a last cup of tea. There will always have been a last time somebody was turned. But it doesn't mean that the morphine, the cup of tea, or turning them killed them. They have died of their illness. But you can feel quite uncomfortable, and I've been in that situation myself, where you've gone in, you've given additional medication because somebody looked uncomfortable, a bit agitated, and then they die, and you think, oh, crumbs, was that linked? But actually, there's no evidence that it was. And there is evidence that if you look after people well, they actually live longer and they live better. So you heard about Oregon. Well, this is just the graph from Oregon's Health Department's latest report. And just to show you, the number of prescriptions are going up. There was this tiny dip last year, but the trend is up. And the number of deaths is up. This looks like a dip, but what we do know is that there are an additional 54 people where we don't know what their ingestion status was. So it may well be that this blue line will be much higher when they're counted in. We don't know, but that's the conservative. And what about the Dutch? The same trend. It's just going up. 15 years of the Dutch experience, and here we are, over 6,000 a year now in Holland. So 1 in 26 of all deaths. That's a lot of deaths. And what happened in the UK? It was being looked at several times, and the House of Commons voted out the last proposal, which was only assisted suicide. It was much, much narrower than the bill you've got before you, and threw it out on grounds of public safety, because it's not safe, by 330 votes to 118. We've got suicide prevention policies intact. As a doctor, I have a difficulty in saying, well, we'll prevent suicide for most people, but actually, or perhaps we'll help you commit suicide. And where do we put the line? How does the conflict work? And the risk to others is just too great. Thank you.